Chest pain in the ED, an induction guide. It's really difficult to write an all-encompassing induction guide to anything in the ED, as we are all so different. So take what I say with a pinch of salt and read around what I'm about to tell you. Ideally, you should see the patient without looking at their past history to keep your mind clear and to not form any cognitive biases. However, it would be reasonable to check the notes for any history of violence or do not see alone alerts. Keep yourself safe, first of all. One of the great things about A&E is to be able to take a history from an undifferentiated patient and say, right, what's going on and what can I do for you? Remember the Oslerism. Listen to the patient. They are telling you the diagnosis. And when you can, allow the patient to deliver their opening statement. You are likely to pick up on the patient's real reason for coming to A&E, and it will genuinely save you time down the line. Start with open questions, then hone in on closed questions. Cardinal symptoms are key. For chest pain, Socrates is a good place to start. Site, onset, character, radiation, associated symptoms, time or duration, exacerbating or relieving factors, and severity. Take a focused history, past medical history, family history and social history, drug history with allergies, and systemic inquiry. With a patient with known ischemic heart disease, I'd like to know if they've had an angio in the past, and what did cardiology find or do. If the patient has aortic stenosis, I'd want to know when the last echo was and what it showed. Keep to the structure of your history template. Ice your patient. What do they think is going on? Do they have specific concerns about their symptoms? For example, their neighbour had something similar and it turned out to be nasty. What do they expect, or what would they like to happen today? There is an aphorism: a careful history will lead to the diagnosis 80% of the time. So in A&E, use a focused exam to rule in or out the differentials you got from your history. I like to do an abbreviated form of an ABCDE approach. The patient's observations should supplement the exam. Come up with a differential diagnosis. One approach is to start with the worst thing that could be going on and go backwards. This is a useful way of rapidly ruling pathology in or out, and I find it uses your brain's slow and fast thinking. This is one to think about. Is an uncommon presentation of a common disease more likely than a common presentation of an uncommon disease? Occam's razor, or the law of diagnostic parsimony, states, the correct diagnosis is the one that makes the fewest assumptions. Conversely, Hickham's dictum states, a patient can have as many diagnoses as he or she damn well pleases. For all these reasons, I find getting a diagnosis the most challenging but the most rewarding aspect of A&E. Split your plan into investigations and treatment. Provide analgesia early for your patient. One of the best things about working in A&E is that there's usually someone nearby who's seen several patients like yours in the past and who can give you good advice. So ask for help if you're not sure. I hope you've got a good idea of the structure of a history and exam so far for chest pain. Right, if I was on a chest pain safari, these would be the big 5 to spot. Each can present with chest pain, but I hope that by doing a decent history and exam that you can differentiate the 5. There now follows a brief musical interlude where I list just some of the other causes of chest pain, and there are many, in patients coming to A&E, taken from the NICE Clinical Knowledge Summary for Chest Pain from August 2022. And don't worry, when I first saw precordial catch, I was like, yes, that's what I get as well. There are links in the notes to some of these pathologies. Finally, some tips when seeing patients with chest pain. It's easy to see doing a troponin as a treatment, but it's actually an investigation. Try and think beyond the troponin. If it's negative, then what? If it's positive, then what? Forward planning and thinking 2 steps ahead of everyone else is a useful skill to acquire in A&E. Beware the chest pain plus syndromes. For example, chest pain plus vomiting, think esophageal rupture or Boerhaave syndrome. Chest pain plus neurology, think aortic dissection or acute aortic syndrome. Don't be afraid to call something non-specific chest pain. There can be a real pressure to diagnose someone or label someone with something like gastritis, musculoskeletal chest pain, or costochondritis. I'd much rather say to a patient, often it's easier in A&E to tell someone what their chest pain isn't rather than what it is. So we make sure we rule out the nasty stuff, and once we've done that, we can go, okay, well, we'll let you go home, but we need to give this time to see if it goes away or persists. And on that same note, giving a good worsening statement to a patient is a skill to learn in A&E. It needs to be smart, specific, measurable, achievable, realistic, and time-oriented. I've just realised some of these only apply to business, but you know what I mean. A great example of this is back pain and red flags. I will try and print out the patient leaflet from BMJ Best Practice on back pain and highlight the red flags for cauda equina to the patient on there. Thank you for listening.